So good evening, all the delegates and faculties. On the behalf of Corona Remedies Private Limited, I welcome all the faculties and delegates for the Searchlight Series 12 live Core Connect live webinar on the topic of non-endometriotic chronic pelvic pain. This webinar is initiated by Cancer Prevention and Relief Society in association with Agra, Bokaro, Bulandshahr, Buldana, Burla, Calicut, Bijnor, and Bhubaneswar Ops and Gynae Society. So first of all, it's my privilege to welcome our convener, Dr. Sujayashree Sangeeta. Ma'am is a consultant of OPS and laparoscopy surgical Seshadri Hospital, and ma'am is founder secretary of Bhimavaram OPS and Gynae Society, and ma'am has got this Shan S. Ratnam Young Gynecologist Award and Foxy Dhira Award. And ma'am is conducting awareness program Vikasam, which is on the adolescent girl for the adolescent girl. So I hand over this session to Dr. Sujayashree Sangeeta and requesting you to please take it forward.
Yeah, thank you, Mr. Mehul, for those kind words of introduction. So I would like to take the privilege of introducing our program director, Dr. Asha ma'am. So we are having these series every Wednesday in the evening. So we're taking this forward. So introducing ma'am. Ma'am is the director of SMSA Hospital Raipur. She's the medical director of CPRS, elected member of CG Medical Council, zonal chair, Foxy Food Drug and MSC Committee West Zone. She's also the chairman, Mission Pink Health, IMA Raipur, executive member, ISCCP, CGI ISAR and CG SFM. Her past post she's held is she's been the president of Raipur OB-GYN Society, vice president of IMA, president Rotary Club of Raipur North. Madam has been the instructor for FCCS OB course, IOTA certification from IOTA.
I think that's enough.
Okay. So yeah, I would
take the program forward.
Madam, yes, I would ask Madam to take it forward. Yes.
So, namaskar, all respected faculty. On behalf of the Searchlight team, I welcome all of you to this webinar. And before we actually start the academics, we start with a prayer. And I would request Mehul, please play the prayer.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
Namaskar, everyone. This is such a busy evening and you have all spared your time to be here. I'm really very, very grateful. I welcome members from Agra, Bokaro, Bulandshahr, Bulthana, Burla, Calicut, Bijnor, Bhubaneswar, Obstetric Gynec Societies who are here. I welcome our chief guest, Dr. Parul sir, and our guests of honor, Dr. Aarti Gupta ma'am, Dr. Komal Chavan ma'am, Dr. Ashok Kumar, I don't see, but he should be logging in anytime. I also welcome our speaker, Dr. Parag Binewale sir, who's been here so early, and our chairpersons, Dr. Pramila Mittal, Dr. Asha Gupta, Dr. Beena Singh. Pramila ma'am is not well, so she will not be joining. I also welcome our experts, Dr. Lakshmi ma'am and Dr. Shubha Ramarao ma'am, and our panelists, Dr. Sadanand Ingle, Dr. Ojaswani Patel, Dr. Indu Singh, Dr. Vinod Rajankar, Dr. Rajesh Ravi, Dr. Shweta Singh, Dr. Jasmeena Banu, and Dr. Sangeeta Chaturvedi. Welcome all of you to this webinar. And I hope we are able to really shed some great light on this topic. When I thought of chronic pelvic pain, when I spoke to 5-6 people, everybody said endometriosis. Get somebody who'll talk endometriosis. So I spoke to Parag sir and requested him, let us speak on non-endometriotic chronic pelvic pain. And he has kindly agreed. So I would request Sujya, would you please introduce our guests of honor, and then we can take the scientific forward. Maybe have the CVs of Aarti ma'am.
Yeah, Mr. Mehul, can you please share this? Yeah. So firstly, we have Dr. Aarti Gupta. Ma'am is the Secretary General, Indian Menopause Society, 2023 to 24. She has also been the President of Agra Obstetrics and Gynecological Society for the year 2020 up to 22. Chairperson of Indian Menopause Society, Public Awareness Committee member. She's been the founder of Satsat Group, and she's also been the chapter secretary for the Indian Menopause Society, joint secretary of AICOG. Ma'am has received numerous awards like the Nari Swasthya Pahal Award, Nari Shakti.
Thanks, dear.
Yeah, but quite a few, ma'am, actually. So it's very nice to have you amidst us, ma'am. Please welcome to this program today. Can we have the next slide, Mr. Mehul? So we have Dr. Ashok Kumar. Sir hasn't logged in, but I will introduce him. Maybe he'll log in a short while. He's the Director, Professor and Head, Department of Obstetrics and Gynecology, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. He's the Vice Chair-elect, ICOG 2024, Secretary of ICOG 2021-23 previously, and he is the present President of Delhi Society. Sir has completed his master's from All India Institute of Medical Science. He's been the editorial member of Indian Journal of Medical Research, Archives of Gynecology and Obstetrics. He has special interest in maternal health. We welcome you, sir. Hope you'll join us shortly. We have Dr. Komal ma'am with us. Ma'am has been she's the Vice President-elect of FOXI 2025, Zonal Coordinator for FOXI President, Core Committee, VAD Cell FOXI, Governing Council Member, ICOG, Chairperson of AMOG's Family Welfare and MTP Committee, Chairperson FOXI Medical Disorders and Pregnancy Committee, Member Managing Council, MOGS Society, Joint Secretary of the Mumbai Chapter, National Expert for FOXI Projects. Ma'am has numerous awards and accolades to her credit. So we welcome you today, ma'am, for today's session. I now request Asha ma'am, would you want to introduce the speaker?
Aarti ma'am, we request you to share your words of blessings with all of us.
Thank you, Dr. Asha. It's my proud privilege to be here with you with such an important webinar on the non-endometriotic chronic pelvic pain. I think this is a very important topic, and this is one of the things which really make us in problem. Many times it's very difficult to diagnose the patients of the pelvic pain. What is the main reason behind it? So I think this is a subject which will enlighten us what are the causes, how we should go through all these problems. I feel at times we give up. No, now we cannot diagnose what we should do. So this is a very important topic, and I am very happy to see so many societies together, which Dr. Asha has taken. I think it's a very good effort. She has taken all the societies, Agra, Bokaro, Bulandshahr, Bulana, Burla, Calicut, Bijnor and Bhubaneswar. So I think it's a very good initiative to take all the societies together. And regarding the chronic pelvic pain, I will like to say that we can diagnose the acute pelvic pain. It's easy because this is basically because of the active tissue damage which recovers. But when we are having the chronic pelvic pain, so this is something very difficult when we are supposed to focus on each and everything. What may be the cause of the chronic pelvic pain? So this is a very important topic. I think we all should go through. Thank you, Dr. Asha. Thank you so much.
Thank you, ma'am. Thank you. Dr. Komal, please say a few words.
Thank you, Dr. Asha. I think what you have thought about as a program, on a focused topic, it is really great because everybody discusses, a lot of aspect endometriosis, as you said, when there is a pain and everybody wants to discuss endometriosis. But we do get so many patients who are non-endometriotic. And the dilemma comes then, how to diagnose, how to manage. And these patients are usually, suffering because we are not able to arrive at a definitive diagnosis. Because our directions, our mind is always thinking about endometriosis. So really, I think the talk and the panel, I think the extensive one topic which you are going to discuss is really, really going to be helpful for all practicing gynecologists. And really great amalgamation. You have societies like from Agra to from north. You have societies of the north. You have Agra and a society of Bokaro, and you have
All
Calicut
four
from south.
zones are there.
But no, but you have missed the west zone. And I think me and Dr. Parag are going to fill in that west zone missed by you. So you have tried to take the three zones, and the west zone is
There.
we are representing. So I think there is a representation from all zones, and wish you all the best. Keep imparting knowledge. Searchlight, the name is right, very nice and a catchy. You're throwing light on a lot of topics with a magnifying glass. So I think we are going to go in depth of it. And so happy that Dr. Aarti Gupta is here. I'm happy to see her. Dr. Parag, who is going to give such a lovely talk. I'm really waiting. Dr. Lakshmi, Dr. Asha, Dr. Shweshri, and all who have joined. I think I'm missing out. I think Ashok sir. So looking forward to interact with all of you, and wishing you all the best. Thank you.
Thank you. Thank you so much, Dr. Komal. Actually, in the societies list, I take them alphabetically. A has come in because it didn't join initially. So I'm already at B and now C. That is how Calicut comes in.
Oh, I was surprised by like all the what is the pattern? Anyway,
The
we are there.
pattern is alphabetical.
Alphabetical. Okay.
Yeah.
Great.
So thank you. Thanks so much for being here. We will be having the blessings of Parul sir and Ashok sir when they join. And meanwhile, thank you everyone for being here. And I would like to have Parag sir's CV so that we can start the scientific and really titillate our gray cells and enjoy. Ashok sir has joined now. Just a second. Ashok sir has joined. Some problem with his audio. Namaskar, Ashok sir. You're most welcome. Please don't mute yourself. Please unmute. And if you could please put on your video, you've been introduced and we seek your blessings for this webinar. Ashok sir?
Yes, sir. Thank you, madam. I don't know my video will be available or yes, it is available.
It is
yes.
available.
So thank you, madam, for giving me this opportunity to be with you. And I am grateful to the chief guest, Dr. Parul Kodawala, ICUG chairperson, guest of honor, Dr. Aarti Manoj Gupta, Dr. Komal Chauhan, and convener, Dr. Shweshri Sangeeta. And I understand that this is your series of program which is going on, and we have very eminent speaker and chairpersons today on the board for this webinar. Welcome Dr. Parag Biniwala and all other faculty. And I hope, madam, this series will continue to be like a shining star to provide knowledge and information to all of us. And all the president and members of Agra, Bokaro, Bulandshahr, Buldana, Burla, Calicut, Bijnor, Bhubaneswar, Opsing Gynae societies participants are there, and I welcome them and thank them for having me here with all of you. And this Searchlight as the name suggests, that we are looking for a shining star, and probably our search will end very soon. And with all the information, I wish you all the success, madam. And I hope your series will continue to provide all the knowledge and information to all of us. So thank you very much.
Thank you, sir. Thanks a lot.
I will introduce the chairpersons, ma'am, and they will be the speaker.
Okay.
So coming to the first session, the chairperson for that session are Dr. Pramila Mittal, ma'am, who hasn't joined us today due to some personal reasons. Madam is the president of Bulandar Society. We wish you were here with us, ma'am. Next, we have Dr. Asha Kumari. Ma'am is the president of Bokaro Obstetrics and Gynecological Society. She's been the ex-HOD of the Bokaro General Hospital. She has participated as a chairperson and panelist in AICOG. We have Dr. Beena Singh, ma'am, with us. She is an alumni of 1983 batch of LLRM Meerut, and she has done her MD from the same college, and she's been awarded a gold medal for being an outstanding student in academics. She has immense knowledge in the field of high-risk obstetrics and urogynecology. She's an expert laparoscopic surgeon, and she is the owner of the Healers Hospital and Beena Prakash Hospital, both at Bijnor. So apart from her medical skills, she's also a director of a naturopathy ashram situated at Khari district, Bijnor. And she is taking care of stray dogs at a dog shelter. And she's also interested in organic farming. So you have multiple interests, ma'am. So welcome to today's session. I request one of the chairpersons to please introduce the speaker for today's talk. Ma'am, Dr. Asha Kumari, would you like to introduce the speaker, ma'am?
Okay. Dr. Parag Biniwale, Senior Consultant, Ops Gynae, Pune, PG Teacher and Unit Head, Kamala Nehru Hospital, Chairman-elect, Indian College of Ops Gynae, and President, Menopause Society, Pune, 2018 and 22. President, Pune Ops Gynae Society, National Website Editor, Foxy, 1117. Peer Reviewer, Journal of Ops Gynae India, 1117, and Chairman Young Talent Promotion Committee, Foxy, 2008-10, co-editor of books Gynecological Manual on Adolescent Girl and Young Woman, Yearbook of Ops Gynae 2019, Exploring New Horizon of Ops Gynae, contributed articles to book and journal, delivered oration guest lecture in over 160 Foxy societies, recipient of Dr. C.S. Don Prize, 51st All India Congress of Ops Gynae in New Delhi, February 2008. Now I request Dr. Parag Biniwale to please continue your speech.
Thank you, Dr. Asha. Good evening. I bring greetings from a warm city, Pune, I should say, because I'm sure in the north still there is some amount of cold scene. We are here in a very, very hot weather. Thank you, Dr. Asha Jain, for considering me worthy as a speaker and giving me an opportunity to reach out to few of the Foxy societies which I have not visited. So Bokaro, Bulandshahr, Buldana, Burla, Calicut, Bijnor and Bhubaneswar are the societies which I have not visited personally. Of course, I've been to Agra umpteen number of times. So thank you for giving this opportunity to me. I think before I speak, Dr. Parul is here, so we can take his blessing before I start my lecture. Dr. Asha?
Dr. Parul, sir.
Hello. Nahi, Parag. Blessings is not the right word.
No, you're the chief guest.
Best wishes is okay, but I mean, you make me feel very old.
No.
Although
that's why I said Parul. I didn't say
so
sir.
very young than me. Anyway, thank you very much, Dr. Asha, for asking me to join up this program. I am very sorry to be so late, but I was also involved in another ICOG program, which we started from today on PPH. But I must compliment you on picking up a topic which is very close to my heart. In fact, lower pelvic pain is an enigma. way back in 2005, when I started my own hospital, I had a joint clinic of 6 specialties for this chronic pelvic pain, because otherwise it is a big problem and patients unfortunately keep on moving here and there, and their families disown them that you have seen so many doctors, everybody says it is in your mind, there is nothing wrong with you. We need a gynecologist, we need an orthopedic surgeon, we need a urologist, we need a gastroenterologist, a musculoskeletal specialist, and if all these are not there, then a psychologist or psychiatrist. So this topic is really vital, and we need to be really inquisitive with the patient to arrive at a proper consultation. So many times it may not be gynec case, and unnecessarily we keep on investigating for a couple of months, and then we say nil gynec, go to orthopedics. He may also undertake some x-rays and MRIs another 2 months, and then she is sent to gastro. So it is time that if you have a good multi-speciality hospital, at least once a week have a joint consultation, so that all of them see simultaneously. That will cut down the patient care time. So I'm sure you will have an excellent webinar on this, and Parag is also there to speak here. I would be curious to see what Parag is telling on this. Thank you very much. And
Thank
I
you,
wish
sir.
you all the best.
Thank
Yes.
you, sir, that you, out of your schedule and having an ICOG meeting, you are here, and Parag sir is here and Ashok sir is here. I'm really very, very honored. And people are actually logging in to hear, because we have sort of trained them that we have a Searchlight which is on a day-to-day topic. Because this patient is always coming to you with a backache or a lower abdominal pain. So thank you, sir. Thank you so much for being here. And over to you, Parag sir, where you can take it forward.
Thank you, Dr. Asha. And Parul, I hope I live up to your expectation. All right. So in next 15 minutes, I'm going to talk about assessment of chronic pelvic pain. And Dr. Asha has very specifically told me not to talk about endometriosis, because the discussion then straight away goes on endometriosis. So what exactly is chronic pelvic pain? If you see the literature, there is no consensus on the definition, but few articles suggest that it can be defined as a non-cyclic pain perceived to be in the pelvic area. And I think all these words are really important. Now, this pain is persistent for 3 to 6 months or even longer, and it is unrelated to pregnancy. So this particular definition tries to speak for itself, where there has to be a non-cyclic pain which is persistent for about 3 to 6 months, and it is not related to pregnancy at all. So chronic pelvic pain has been reported to affect up to 25% women of reproductive age group. Now, this is something which is a symptom that can represent pathology in a specific organ system, or it could be part of chronic pain syndrome, or both. So whenever we are evaluating, there are two important goals we have to understand. First, try and identify a cause of pain which is treatable. And secondly, differentiating specific peripheral causes from those overlapping with centralized pain syndromes. So we really have to take extra efforts to see to it that we come to a diagnosis. And what Dr. Parul said is absolutely important, because we do need a multidisciplinary approach to investigate these women and try and find solution for these women. So chronic pelvic pain affects women of all ages, but it is the younger women between the age of say 27 and 29 who are found to be affected more. The average duration of symptom reported by women is generally around 2.5 years, which is really something which we have to take very, very seriously. 2.5 years of suffering is not something that needs to be ignored. there may not be any significant correlation with mean gravidity or parity or rates of elective abortions or even racial distribution or mean educational attainment. So women from all strata of social factors can come up with the problem, which can be identified as chronic pelvic pain. And the prevalence is ranging in different studies, varies from 4% to 25%. So it is important that we approach this particular problem holistically. First of all, gather and review all available data. So if the woman has undergone a foray of tests earlier, ask for those reports before you actually examine her. So after detailed history taking, it is important that we review whatever reports that are available. Secondly, we must recognize that initial clinical evaluation and counseling may require more than one office visit. So it is not possible for us to decipher the enigma of chronic pelvic pain in just one sitting. We may have to see the patient repeatedly with the help of our colleagues in order to find out what is the exact underlying problem. Thirdly, we must utilize standardized questionnaire to elicit the history, associated symptoms, the success and failure of prior treatments, and then the physical examination. And we must perform a physical examination. We should also assess for mental health concerns and complete targeted testing. Coming to the etiology of CPP, and practically all organs which are located in the abdominal cavity and even some of them outside can be responsible for chronic pelvic pain. As far as our specialty is concerned, apart from endometriosis, it could be leiomyoma, adenomyosis, recurrent ovarian cyst, hydrosalpinx. Very, very rarely we may have women who come to us with ovarian remnant syndrome, pelvic inflammatory diseases, pelvic adhesion disease, post-tubal insert pain syndrome, and malignancy. Let's not forget our neighbor, the urological system, where it could be because of interstitial cystitis or painful bladder syndrome, or even different reasons why there is cystitis or even urolithiasis. There are certain causes like irritable bowel syndrome or inflammatory bowel disease, rarely colorectal carcinoma, which may present with chronic pelvic pain. Certain musculoskeletal disorders, including pelvic floor tension myalgia or abdominal wall myofascial pain, can come to us with chronic pelvic pain. And very rarely, it could be a neurologic origin or very, very rarely a vascular origin, which where we could be dealing with a woman who has pelvic congestion syndrome or even vulvar varicosities, which may be perceived as chronic pelvic pain by the woman. So whenever any woman comes to our clinic with the complaints suggestive of chronic pelvic pain, it is important that we take history in detail. And like in our second MBBS classes, we are taught how we should take history in detail. This is one area where we should focus totally on history taking, because then we will be able to come to a conclusion what kind of disease the woman is suffering from. So we should ask for past medical and surgical history. We should focus on past menstrual history, present use of contraceptives, prior obstetric history, and even gynecological history. Of course, if there is history suggestive of endometriosis or pelvic inflammation or other conditions, we should inquire in detail. The next important thing is to assess the characteristic of the pain. So look at the associated findings. What are the provocative and palliative factors, the quality of pain, radiation of pain, settings in which pain occurs, or the timing when the pain occurs, and events that precede or trigger the pain. We must also elicit psychosocial history with a focus on substance abuse, alcohol, marijuana, or prescribed medications, We should also look at the patient safety, whether this particular patient has current or past history of physical, sexual, or emotional abuse. Ask for prior diagnostic tests and pain treatments, and inquire about family history of relevant clinical conditions such as chronic pain syndromes. The assessment of patient is very, very important, and this is the International Pelvic Pain Society, which gives us a very important pelvic pain assessment form. This is very much available on the net and we can download it. So it is really important that whenever we are dealing with a woman who has chronic pelvic pain, we should use this pro forma to assess the nature of symptoms that the woman suffers from. It is also important to find out how much is the suffering, whether it is on a daily basis, how many times a month she's suffering, and the monthly pain scale will tell us exactly the real situation that the woman is going through. We should also ask for provocative factors as well as palliative factors. So we must understand the factors that provoke, that is worsen the pain, or alleviate, that is lessen the pain, and this will certainly help contribute to a differential diagnosis. So pain that worsens with eating or improves with bowel movements is suggestive of gastrointestinal process. Pain with urination or defecation can result from deep infiltrating endometriosis as well as functional and pathological disorders of the bladder or the intestine. So it could be a bladder pain syndrome, irritable bowel syndrome, or even inflammatory bowel disease. Pain that is altered, it may be increased or decreased with specific activities or position changes, suggests a musculoskeleton or vascular etiology. And irritable bowel pain and bladder pain syndrome are typically associated with some degree of impaired visceral function. We should also ask how the pain is radiating. So a pain that starts in the back and then wraps around the torso and or radiates to the upper thighs may be suggestive of pelvic girdle dysfunction. Chronic nephrolithiasis, though uncommon, will have classic renal colic with radiation of the pain to the flanks. So from the flanks to or from the loin to the groin is the typical description of this pain. And this could be experienced by the patient repeatedly. A chronic abdominal pain with radiation to the shoulders and back may be suggestive of chronic pancreatitis. So it is really important for us to find out how the nature of the pain is. It is extremely important that the patient undergoes a psychological assessment because she may not have any physical issues, but she may have underlying psychiatric disorder. There could be a certain sleep disorder which may be responsible for chronic pelvic pain. Similarly, abuse, physical, emotional, sexual, or even related to childhood neglect, and detailed history of this will certainly add value when we are investigating the woman for chronic pelvic pain. And of course, opiate and substance dependency and somatic sensitivity should be inquired into. Coming to the examination. So general examination is important. So we should look for vital signs. General appearance is also important because it will tell us the mood, affect, or emotional state of the patient. Observe carefully the gait and posture. Examine the back, look at the pelvic spine curvature, look for any evidence of previous injury or surgery. Abdominal examination, so look at the appearance of the abdomen, look at the scars or evidence of previous trauma or surgery. Look for masses, hernia, inguinal adenopathy, or pubic symphysis pain. Light palpation of or stroking will be important to evaluate for allodynia, and single-digit deep palpation to differentiate focal versus diffuse pain. And of course, we should look at the trigger points. And looking at the extremities is also important about the movements of joints, especially the hip joint, plus look for muscle strength, tone, spasticity, and asymmetry. Coming to the gynecological examination, have a look at the external genitalia, whether there are any lesions or ulcerations or even abrasions, erythema or edema of the external genitalia, or it could be a clitoral problem or a urethral meatal issue. Look at the vulva or the vestibule. So cotton swab examination if the patient has vulvar pain or dyspareunia. A gentle single-digit examination should be performed. Look for the tenderness and spasticity of pelvic muscle floors. Here, we should also examine the urethra, bladder, cervix, lower uterine segment, and the vaginal fornices. The bimanual examination is important to determine the size of the uterus, mobility of the uterus. A uterus which is fixed, we are probably dealing with a chronic pelvic inflammatory disease, or if we are probably dealing with an endometriosis. Look for tenderness, look for palpable adnexal masses. A rectovaginal examination is important, so look for tenderness and or nodularity of rectovaginal septum and uterosacral ligaments. And a speculum examination, we cannot forget it. Look at the cervix, look at the lesions, ulcerations, erythema of the vaginal mucosa or cervix, or even try to look at the posterior vaginal fornix. Sometimes an injury in the posterior vaginal fornix may lead to chronic pelvic pain if it remains untreated. So this is in general the algorithm that we follow. So women who come to us with chronic pelvic pains, we should look at whether she has painful bladder syndrome or a provoked vestibulodynia, and then a Q-tip test with a cotton swab will tell us whether it is related to the vestibule or the bladder. If it is a case of painful bladder syndrome, she may come to us with a complaint of urgent or frequent need to urinate, difficulty with sexual intercourse, depression, anxiety, interrupted sleep, and manual examination of the pelvis may find tension, rigidity, and even sensitivity of the pelvic muscle floors or the myofascial trigger points. Coming to the laboratory test. Now, these tests may not be of great help, but we should look at some tests which may give us certain clue. So these tests basically are done to exclude other causes for which the patient has come to us. If she's sexually active, if you're suspecting, do a pregnancy test first. It is important that we do urine analysis and urine culture if needed. Hemogram and CRP is important. The women who have gastrointestinal symptoms, they should undergo testing for intestinal infections. It is important that we look at the cervix and take this opportunity to do a pap smear and HPV testing. It is also important for us to think of gonorrhea, chlamydia, and trichomoniasis if we feel so, and vaginal cultures at times may be required. Coming to the imaging study. Now, imaging techniques can be useful to identify structural causes of chronic pelvic pain, such as uterine leiomyoma or ovarian cyst. When the imaging is deemed to be an approximate next step, it is recommended that pelvic ultrasound details information should be revealed as far as the pelvis is concerned, and it is relatively inexpensive, widely available, and it avoids ionizing radiation. For women in whom pelvic ultrasound is unclear or who need further investigations, MRI of the soft tissue abnormalities or computerized tomography for evaluation of bony structures or the intestines and the ureters may be considered. So coming to an ultrasound, a pelvic ultrasound is typically performed for females who come to us with acute or chronic pelvic pain, who typically may exhibit a large uterus, adnexal masses, or other structural abnormalities on physical examination, or women who specifically come to us with heavy or irregular menstrual bleeding. Now, a transvaginal ultrasound is of utmost importance, and a 3D ultrasound with color Doppler used judiciously would certainly add value to our diagnosis. So the ultrasound in different gynec pathologies. Now, uterine leiomyoma or ovarian cyst or masses can cause pain. All of us know that. A complex adnexal mass can be the result of endometriosis. Adenomyosis can cause pain with abnormal uterine bleeding and can be suggested by an ultrasound finding, although son ultrasound cannot provide a definitive diagnosis. If there are intra-abdominal adhesions or postoperative changes, especially in women who've undergone previous pelvic surgeries or women who suffer from pelvic inflammatory diseases, or simple or complex cysts of peritoneum or other structures are relatively common following pelvic surgery, but they may not be typically associated with pain. So MRI will be useful in women who have large fibroids or ovarian masses, or even for endometriosis and adenomyosis. Coming to the other modalities, so ionizing radiation in women with chronic pelvic pain where no clear acute process is present, or we may consider computerized tomography to look at the intestines to rule out enteritis or colitis, and pelvic venography just for the diagnosis of pelvic congestion syndrome is quite controversial. So laparoscopy is an important tool and it can be used for both diagnosis as well as treatment. So here, if we are quite sure of the diagnosis, then laparoscopy should be used judiciously or more commonly, because you will be able to see and treat the condition in the same go. So in endometriosis, or even women who have pelvic adhesions, or even say hydrosalpinx or pyosalpinx, we can consider doing laparoscopy to see and treat the condition. But here, let's not forget the surgical risks which are associated with the procedure. Mind well, it is a procedure which is to be done under anesthesia in a good setting. Also, we need an expert who's able to tackle all these issues should be present. So we should look at it very, very judiciously and use it, especially when needed. Don't forget the surgical risk like bleeding, infections, etc. Coming to the first condition, which is so common, and that is pelvic inflammatory disease. Now, 30% of women who have pelvic inflammation will eventually land up in chronic pelvic pain. And these are the women who really are harassed by the pain, and we are not in a position to offer them any specific treatment. So women with chronic pelvic pain, especially of the uterine origin, history of PID, and no other identifiable causes of chronic pelvic pains are offered neuromodulators. Now, in chronic pelvic inflammation, hydrosalpinx will look something like this. So here it looks like a tubular dilated cystic structure, that is hydrosalpinx, and then we should also look at the adnexa and the nodular appearance by itself. So this is the algorithm which talks about the neuropathic pain. There are so many agents which are available, which I'm sure will be discussed in the panel discussion on management. The next issue is pelvic adhesions. Now, while adhesions are often asymptomatic, most patients with symptomatic adhesions will have a history of previous pelvic surgery or an intra-abdominal or pelvic inflammatory process. We really don't know whether these adhesions are responsible for chronic pelvic pain, but if there are adhesions and if the woman is not suffering from chronic pelvic pain, the adhesiolysis may not be of great benefit. One condition which is enigmatic is the pelvic congestion syndrome, and the characteristic symptom of shifting location of pain, deep dyspareunia, postcoital pain, and exacerbation of pain after prolonged standing are associated with radiological findings of pelvic varicosities. So the picture shows how the ultrasound, and the Doppler picture shows how the pelvic varicosities look like. Unfortunately, the ideal diagnostic test cutoff values, whether using MRI, venography, or ultrasound have not been definitively established. So we really have to correlate the clinical findings with whatever detailed ultrasound or color Doppler report that we have. A very rare entity that is ovarian remnant and residual ovary syndrome. So ovarian remnant syndrome occurs in patients who have undergone bilateral oophorectomy and subsequently present with symptoms related to ovulatory function from the ovarian tissue, which is left behind inadvertently. This can be distinguished from the residual ovary syndrome, in which the ovary was intentionally preserved and subsequently develops pathology. The typical patient presents with cyclic pain and a mass, although the pain may be persistent with acute flare-ups. Occasionally, an asymptomatic mass is detected on pelvis or examination or an ultrasound examination. So this is the flow diagram, which talks about management of pelvic pain. We are leaving aside the acute part, but the chronic pain, more than 3 months, laparoscopy would be a good tool. And if there is some positive diagnosis, we should treat it at the same sitting, and then we expect that the pain resolves. But if the laparoscopy is negative, we must rule out functional and psychological causes and then see if the pain resolves or not. So to conclude, non-cyclic pain perceived to be in the pelvic area that lasts for 3 to 6 months or longer, and it is unrelated to pregnancy. So this is the typical characteristic of chronic pelvic pain. It has been reported to affect up to approximately 25% women of reproductive age group. Stepwise evaluation, detailed history, thorough physical examination, and additional testing is important. Use various investigative modalities judiciously and to the benefit of the woman. And laparoscopy can be both diagnostic as well as therapeutic, but should be used in select patient in which you would feel that the procedure will be of benefit rather than harm. So thank you very much. Once again, thank you, Dr. Asha, for inviting me here. I hope I lived up to your expectation.
Thank you, sir. You've touched everything. Over to the chairpersons, please.
Thank you, Dr. Parag. You have presented your topic that is on chronic pelvic pain, which is very difficult to treat in a very wonderful way. Whenever a patient comes to OPD with CPP, several factors come into our mind, like gynecological, non-gynecological, but we should not forget the psychiatric disorder as well as the neuropathic pain and substance abuse and the social problems that can also be detected by proper history taking. Thank you once again that you have presented your topic in such a easy way that it will help many gynecologists to treat the patient with chronic pelvic pain. Thank you.
Thank you so much, sir. As Parul sir is still here, sir, if you are here, we would love to hear a few words from you.
No, Parag has been very comprehensive, but the best way to deal with this might be sharing of cases. Okay, I'll just share one case of mine with you all. It will take 2 minutes. Years back, young lady around 28, had come from London, and she approached me in one of the corporate hospital where I was a consultant. She had a dragging sensation from below. That was her only complaint. Caesarean section before 1 year. She had that dragging sensation, and in UK, she had undergone extensive investigations. And the last doctor had prescribed ECT, electroconvulsive therapy, saying that it is all in her mind. Okay. Now, after her examination, I also could not figure out what problem she has, but I told her that two things might be possible. One is subclinical prolapse, or one may be additions because of the surgery. I put in a ring pessary. Within 2 days, she got back that no, this is very painful and take it out. So we removed that. And she was not ready to undergo a laparoscopy because already she had undergone one laparoscopy in UK for this problem itself. But she did not have any reports with her. And there was only one incision of laparoscope. So it was a single puncture laparoscopy done there. Her mother-in-law or mother was with her, and she said that her husband has abandoned her, saying that, see, doctors have said it is all in your mind. And she insisted on this girl that you have to undergo whatever the doctor tells you. I am not going to take you back to UK. So with reluctance, she agreed, and we put in a laparoscope. And there was one omental bend going to the right angle of the cesarean section scar. Only that was there, and I cut that, and her pain went off. She was not ready to believe. I had to show her her video that, see, this was there. She said, how did they miss it in UK where they had already done a laparoscopy? I said, whatever. And even after going back, she wrote back to me, doctor, you changed my life. So such small thing. Parag did touch upon the laparoscopy as both diagnostic as well as therapeutic. So we have to be inquisitive. There are a couple of more such cases, but this was just to give you an idea that things can happen to people. If there is any previous surgery, think of additions, because that is one thing which people miss out. 40% of intestinal, I mean, abdominal pain is because of intestinal adhesions due to prior surgery. So adhesion is one area which we as gynecologists need to keep in mind as a big source, which sometimes we miss out. Okay, and I do compliment Parag for being so comprehensive and complete, thorough in his covering the entire topic.
Yeah, thank you, Parul.
Yeah, please carry on. Asha, you are muted.
Thank you, sir. Thanks a lot. Thank you, Parag, sir, for that really comprehensive lecture and actually not talking about endometriosis. Thanks a lot. So I think we'll proceed to the panel now. Mehul? Yeah, you were going to say something, Sujia?
No, nothing, ma'am. I was requesting Mehul for the slides. Yeah.
So we have two experts with us today. We have Dr. Lakshmi S., who's the president of Calicut Obstetric Gynec Society, and she's an additional professor, Department of Gynae, Government Medical College, Kozhikode. She's the president, Calicut, and her special interests are high-risk pregnancy, endoscopy, and fetal medicine. So welcome, ma'am. I have also called in and requested Shubha Ramarao, ma'am, who is the president of BSOG, senior consultant and former head of the department St. Martha's Hospital, DNB teacher, guide, and examiner, and a very, very quiet but very knowledgeable faculty. And it's a great honor to have her here as an expert so that with her experience, all our queries can be solved quite easily. I would like to introduce my panelists as well. We have Dr. Ingle, who's the president of Bulthana Society, Dr. Ojaswini Patel, ma'am, who's the president of Burla Society, Dr. Indu Singh, ma'am, who's the secretary of Bulandshahr Society, Dr. Vinod Rajankar, secretary Bulthana Society, Dr. Rijesh Ravi, who actually provided me with Lakshmi ma'am's number. He's the secretary of Calicut Society, Dr. Shweta Singh, professor and head at AIIMS Bhubaneswar, Dr. Jasmina Vano, associate professor AIIMS Bhubaneswar, and Dr. Sangeeta Chaturvedi, who's the secretary-elect of Agra Obstetric Gynec Society. With all these galaxy of knowledgeable persons, we will now proceed with the panel. Just a second. So my initial slides are just the slides that Parul sir has already dealt with. So instead of repeating them, I would now directly go to the cases and we can have input from everyone on those cases. I'm not going to take names or anything because this is something that everybody needs to give an input on. There's a 38-year-old woman who presents with chronic pelvic pain localized on the left side. She reports that the pain worsens with prolonged sitting or standing and improves with rest. What are you going to do next? Anyone on the panel, please? She has come that she has that pain on the left side, and when she's sitting for a long time.
Yes, Asa madam.
Yes, ma'am. Jasmine ma'am, namaste.
Yeah, namaste, madam. So at the outset, I am thankful to you, madam, for incorporating me in this panel. And as already it has been discussed vividly by Parag sir and also input by Parul sir. So this could be a case of chronic pelvic pain, mostly resulting from the musculoskeletal disorder, because here some points hints the diagnosis, like she is having pain in one side that is localized primarily to the left side, and she is complaining of the pain which worsening. There is an aggravating factor is there. There is the certain posture change, prolonged sitting or standing, and there is also a relieving factor is there in the form of rest. When she is resting, the pain is slightly relieved. So probably there is a musculoskeletal component which contributes to chronic pelvic pain in this woman.
Thank you, ma'am. But you know, she is a case, she has come to you. Here yes, we know that is going to be musculoskeletal, but
yes, ma'am.
When she comes to you, you don't know that, right? So what yes, are you going to do when she comes to you? She has said that she has that pain. It's on the left side. And
yes, ma'am, we have to take the thorough history of this patient.
Yes, ma'am.
And in the form of her menstrual history, her obstetric status, about the mode of delivery, whether there is an instrumental delivery, what is the puerperam period, whether there is any sepsis was there or not, and what is about her menstrual history also. You have to ask for that. And also about her any pain in the genitalia, in the form, in the vulva, vagina, or in the pelvic floor pain, or about her urinary symptoms and the rectal symptoms. It is a whole panel with thorough history taking from head to toe is quite necessary, and we should give time to take the history properly, and accordingly have to again examine in a vivid manner, as already sir has told. And here, apart from all the examination routinely that we are doing following for a gynecological patient, we have to also examine the musculoskeletal system, like the localized tenderness or any point, then the leg raising test. So if there is a leg raising test, it is painful, pain is aggravated, probably it is pain of the musculoskeletal system. But with the leg raising test, the pain is slightly decreased, or we are not able to identify the proper site of the pain, probably it may be visceral pain. So here, all the things according to whether she is able to do her job, suppose she is a housewife or any working lady, whether this pain is compromising her day-to-day activity, we have to also ask for that. Any psychological component, any marital disharmony, any sexual abuse in at present or in the past, we have to ask in detail and examine, and later on we can go for the investigation. As far as told, investigation.
Thank you, Jaswini ma'am.
Ma'am, I think we'll look into the differential diagnosis based on the history. That would be throws more light on what would your DDs be based on the history, ma'am. Any of the panelists could take this question.
I would like Lakshmi ma'am to say something about, how are we going to actually focus on the pain scale and everything? Practically, what are we using?
Yeah, definitely. Because see, to me, what concerns me is that she's a very young woman who's come with such a problem. That is, though primarily it points to a musculoskeletal problem, as Dr. Ojaswini has said, my first importance would be to take a detailed history. I wouldn't want to elaborate on all the points. And being a gynecologist, my primary aim would be to rule out all gynecological pelvic problems. And then I would concentrate more. Of course, my digital examination might throw a clue as to whether there is any trigger point in the pelvic floor. And definitely, I'm more interested to know what her BMI would be like, because whether she is obese, because all that would be important in counseling her regarding her lifestyle modification, counseling her regarding the physiotherapy. And of course, what was the nature of birth, whether she had a traumatic delivery, because why should a 38-year-old woman have a musculoskeletal problem at a young age? Because this is not the age we expect them to have this. Though I would definitely think of it in an older woman. So this patient needs a thorough evaluation, both with the investigations, ultrasound, and X-ray of the lower spine and the pelvis, and of course an MRI if indicated. And one has to move along those lines. And if there is a detectable musculoskeletal problem, my focus would be on directing her to a physiotherapist who would be the best person to advise her regarding relaxation exercises and pelvic floor muscle exercises, reduction of weight, modification of her dietary problems, whether she's constipated, and of course her lifestyle, whether she's too sedentary at her workplace. That is also important, because then she may also have to change her lifestyle a little bit.
Okay. Dr. Shweta, would you like to add something here?
Thank you, ma'am, for bringing me in. Good evening, everyone. I agree with both our panelists very well. They've told about everything. BMI is very important because on sitting, so maybe if the weight is more, that would be one problem, sedentary lifestyle. I would like to get an ortho or a PMR consultation for her, because this really would be beyond my scope if it is a musculoskeletal thing. So a multidisciplinary team approach towards a patient also helps a lot. And the other thing is, many times we have the somatization syndromes that patients would be complaining of pain in one organ, but actually the reason would be something else. So you speak to them, they start crying, we send psychiatry referrals, and then finally find out that they are mild to moderately depressed because 38-year-old midlife. So a lot of things would be there. Also, I would want to look for any previous history of cesareans or any other surgeries, because a lot of times, like Parul sir said, we get these surgical adhesions as the cause of pain. In this case, it is not shown, but then things can coexist also. So these are certain things that we would like to, before we tell it is chronic pelvic pain and musculoskeletal, we need to rule out a lot of other important, at least gynecological conditions. So that's
Here
from my
I
side.
have a very, very, I have stars in this panel. So I want to ask you this: at the age of 38 years, she has a sacroiliac joint pain. She has decreased movement in her left hip. There's no past history of injury. Would you correlate it with tuberculosis?
Yes,
and
ma'am.
then search for some tuberculosis in the pelvis?
Sure.
Definitely, that's why an ortho consultation, actually, see, we also have a project on.
A patient would not have directly bone tuberculosis. It has to come from somewhere within.
Yeah.
So are you going to search for it in your department? Because that has to be a doubt in your head that this could be a pelvic tuberculosis.
Madam, one thing
can be, but unlikely.
No,
it can be, ma'am. It might be due to malnutrition, ma'am. A lot of patients of this age group, they are malnourished, and we have to look to that aspect also.
Osteoporosis may also be there.
Madam, one thing, in our areas in Western Odisha, sickle cell disease is a common problem. And here, many times the women, they present in this age group, they present with the femoral head necrosis because of this sickle cell crisis, vaso-occlusive crisis. And they usually come with a limping gait and pain in the hip joint also.
Okay. Shubha ma'am, would you like to add something before we proceed further?
Yeah, definitely we have to keep tuberculosis in mind. A good examination of the spine, very important, because, you know, sometimes spinal tuberculosis, I've seen a case wherein the, because of the caseous material along the spine had tracked on along the nerves into the pelvis, and patient had come with chronic pain. And it actually, this was some years back when imaging was not so very good. And we had done a laparotomy thinking that, you know, something is there, but it was negative. And finally, it was diagnosed as tuberculous spine with the caseous material, you know, the tracking down into the pelvis. So in India, we have to keep, whether it's a well-to-do patient or not well-to-do, we have to keep tuberculosis in mind. And of course, with all the imaging, it has made things easier. But as gynecologists, we have to do simple tests like examination of the spine, looking for localized tenderness, and do the leg raising test, and also the head raising, so that we will be able to distinguish whether that pain is musculoskeletal or it is something within the pelvis.
Okay. Okay. So
Madam, adding on to the, excuse me.
Yes, sir.
Madam, adding on to the musculoskeletal pain, we should also think if any young patient comes, we should also be thinking of connective tissue disorders, where the ligament laxity is also a common problem leading to all these musculoskeletal issues.
Yes.
The connective tissue, underlying connective tissue disorder may also predispose to this condition.
Agreed. Agreed.
See, in this case, it was the localized left-sided pain, right? So there can be referred pain because of the hip or because of the sacroiliac joint. And there may be problems secondary to things in the lower leg. That is, even the knee and even a flat feet and things like that, you know, they causes unequal distribution of weight and can cause some chronic changes in the pelvic structure itself. Therefore, we must do a proper general examination and see if there's anything other than anything in the pelvis which can cause pain.
And, may not be particularly relevant to this case, but any woman, anyone who comes with a musculoskeletal problem, I would also be worried about the vitamin D levels in them, because this is something we see very rampantly today, vitamin D deficiency. So correcting vitamin D deficiency and calcium is primarily also our responsibility to be aware of this when we deal with purely musculoskeletal problems.
Means I totally agree with that, because patients will go from one specialty to another, with pain, and nobody is actually checking their levels. And even if they are checking, they are not giving the therapeutic dose of vitamin D. So it doesn't really work. So we need to look at the vitamin D levels. One point in musculoskeletal that I would like to add here is that many of our women who deliver vaginally, and they are, you know, for 2 weeks, 3 weeks, whatever, they are at home, and then they start working, and they have no time to rehabilitate their pelvic floor and also their abdominal muscles. So when they lie down, when you touch their core muscles, they are absolutely non-existent. And if the core muscles are non-existent, the spine will be loaded. It will always have pain. And whichever nerve is compressed, in that area, that pain will be felt. I have had patients with vulval area pain, vaginal pain, pelvic pain, and it was just strengthening of the core muscles and supplementing with vitamin D that made them very much better. So that's a very, very important point that you have raised. So we've almost done with these questions. How are we going to check for pelvic floor dysfunction in this case? She has pain in her back, agreed. But how are we going to check for her pelvic floor? Dr. Jasmina?
Yes, madam, because she has come with the problem. So I think we have to have a thorough examination, pelvic examination. So we can, from the history, we could have extracted the incontinence problem, sexual dyspareunia problem, whether she's having any dyspareunia or whether there is any bladder and bowel incontinence is there. And while examination, we have to give more importance to the pelvic floor examinations. Like we have to examine the tone, tenderness, and the trigger points in the myofascial area of the pelvic floor muscle. From that, we can come to know whether she's having any pelvic floor dysfunction.
So this patient was finally diagnosed with pelvic floor dysfunction secondary to sacroiliac joint dysfunction or hip pathology. Now we go to case number 2, and it's a 45-year-old woman who complains of chronic pelvic pain accompanied by bloating and changes in bowel habits. The pain is often relieved after a bowel movement but returns shortly afterwards. She has a history of constipation and abdominal surgeries. So, what are you going to do with her now? What are you going to do with her? She is there in your OPD. Anyone can take it.
Ma'am, first of all, hello, ma'am. Good evening, everyone. Ma'am, first of all, we need to take a detailed history regarding the bowel movements prior, and is there any recent change in the bowel movements, and the associated things with the pain factors which are aggravating or relieving this pain, and along with any history of surgery. Abdominal surgery is already there, so there might be some this surgical factor also related to this chronic pelvic pain.
Dr. Shweta?
Yeah, thank you, ma'am. So this middle-aged woman, 45-year-old with bowel changes, I'll definitely like to take a good history, whether there's any family history associated of any cancers, and her own history about what type of bowel movements, whether it is related to menstrual cycle, because many people will have it during their menstruation, and whether it is associated premenstrually or is it that at all times it is there. So a thorough history will tell us a lot of things, any surgery, especially sections, any open like mini lab for sterilization, so all those things. And then go ahead for a PV and a PS examination so that we rule out any gynecological causes. Because many times we find that this GI and the genitourinary and the bowels, they are all interlinked. They complain of one thing, but you find something else. So rule out all the gynecological causes. And then, since we have the luxury of having the gastroenterologist and all the specialties and super specialties in our hospital, so I definitely would think of it as a gastro case and send them to medical gastroenterologist, because they do a lot of other tests and maybe they will come up with something which will be beneficial to the patients. So then we see how, like, what comes out of it. Because
Lakshmi ma'am?
constipation by itself is a big thing. Abdominal surgeries, yes, that can be a co-factor. But regarding this constipation and bowel changes, definitely a gastro opinion. If you don't have gastro, a medicine opinion will also help.
Lakshmi ma'am, would you like to add something?
Yeah, in this woman particularly, because she comes with an alteration and change in her bowel habits, mainly depends upon the duration. If it's a very short, if it's not a very chronic problem since lasting for many years, I would definitely want to rule out malignancy in her, because this is a very important way in which malignancy can present. And so, as has been repeatedly said, after thorough history and clinical examination, I would definitely rely on the imaging studies, rule out malignancy, and then put my diagnosis as an irritable bowel syndrome. And IBS can be predominantly constipation oriented, or it can be more of diarrhea, or it may be simply pain. So it depends. If she's constipated, then I would advise her a high fiber diet, asking her to have plenty of fluids. Avoid sometimes dairy products can really precipitate more of irritable bowel symptoms. So that should be avoided. And some practical advice can be given. And of course, antispasmodics might relieve her symptoms to an extent if it is only irritable bowel. And sometimes we may have to think of neuromodulators as well.
Okay. Okay. Dr. Rajesh? Dr. Rajesh? He is not there. Dr. Sangeeta? See, what I want to ask you, a very basic, simple thing, that when I was in medical college and a patient came with the complaint that she's having sometimes loose motions, sometimes she's having diarrhea, and the pain is relieved by passing motion. The first thing that came into our heads was amoebiasis. We have to remember that in our place, still in India, not everybody has access to potable water. And amoebiasis is very rampant. So a simple stool examination is going to take care of it. Also for ovacyst and malignancy of the GIT, if you are expecting, then occult blood for that. A stool examination for ovacyst and occult blood before you can subject her to very many different investigations. It's just a suggestion, and I would like to take your opinion on this.
Yeah, definitely. As you said, any alteration in bowel habits, we definitely think of the common causes like worm infestations and amoebiasis. But here you mentioned she has a history of constipation. So generally, constipation is not often seen when you have an intestinal infection. Anyway, that has to be also thought of. And of course, we go in lines with the history and examination, and if needed, the further imaging modalities.
Ma'am, we have to, am I audible, ma'am?
Yes, ma'am.
Ma'am, we have to take the history of any drug intake, whether she is taking it very chronically and she is constipated because of this, and some smoking or some alcohol, any addicted to anything, and or any tobacco. So because of this, she is having bowel disorders and having pain continuously. We have to ask the history in very detail.
Okay.
Madam,
So
one thing.
Yes, ma'am. Ma'am, you're muted. Ojaswini, ma'am, you're muted.
Yes, ma'am. As the main complaint is her bloating and irregular bowel habit, and she is a female of 45 age. So we have to think of the gallstone also. The female 40, fertile and fair like this. And also there's simple acid peptic disorder. And this pancreatitis. We have to think of the upper GI tract also, like the hepatobiliary system and the gallstone, all these things.
Shubha, ma'am?
Yeah, I think this patient, sorry, I've been on and off the screen because I have this bouts of cough. I wasn't keeping well. So the thing is, in this case, definitely she has bowel symptoms along with some pain, and therefore she needs a thorough evaluation. Once we find that there's no obvious pelvic pathology, I will definitely refer her to a surgeon who needs to evaluate her completely because she has a changed bowel habit, she has constipation, and she also has other abdominal symptoms. So she will need a PR, proctoscopy, and even maybe colonoscopy to establish any, to rule out any major pathology. And then if it is simple irritable bowel syndrome, where mainly the physician is the one who's going to treat her. Nowadays, so many drugs are available for IBS, and also, lifestyle, a bit of a lifestyle change, dietary modification, all that also is going to help her for irritable bowel syndrome.
Thank you, ma'am. Actually, one of our colleagues, her daughter, who's only 30 years old, developed constipation. 5-6 months she had constipation. Then she said that I'm having bleeding because I put too much of pressure. When they put in a proctoscope, she had a rectal malignancy.
Yes.
And less than 30 years of old, my classmate's daughter. So we have to be alert to everything. And it could be a simple thing like an infection. It could also be a malignancy. So I remember in college when we were reading Hutchinson, it's written that every disease is psychological after you have proved that it is not anything else.
Yeah.
So you cannot put the psychological thing first.
Yes.
In fact, now I would like to share this case wherein this pregnant lady had some loose motion. She was in her early second trimester and she went to the gynecologist. And I, for one, I asked this lady lots of questions to see if her loose motion was anything unusual. It was not anything unusual. We would have said, you have eaten some pani puri, something outside, or, something like that. But that gynecologist did a PR for her. And I had really no reason why she did a PR. And lo and behold, she found a rectal mass. And then this girl underwent, termination of pregnancy with AP resection and whatnot. I mean, young girl, 23, 24 years old only. So sometimes it's kind of, I don't know, third, sixth sense or something which tells the doctor. Tell me who of us would have done a PR for a pregnant lady who has come and has had some loose motion for one day? None of us would have done a PR. I don't know why that gynecologist did, and she discovered CA rectum.
Did she have any bleeding per rectum?
Nothing. I asked the girl lots of questions. I said, because I was surprised why a gynecologist did a PR for her for loose motion. So I asked her whether it was mucus diarrhea, whether it was persistent long time, whether it was bleeding, whether she had, purging, watery discharge, whatever. She said, no, I just had 3-4 loose motions, and because I'm pregnant, I went to the doctor. I said it could have been because of the iron also, but she had not yet started her on iron. So it was early, maybe 15, 16 weeks or something. She had not yet started her on iron. So frankly, I don't know. And then when they had come to me, it was 4-5 years post-surgery and treatment. And they wanted to know whether, they can go ahead and have a baby. Of course, I saw them twice and then they did not come back to me. Yeah.
Ma'am, so here I think we need to be alert about it. That is one thing, both things. And one thing that we have not actually thought about is taking a detailed family history. None of us have discussed today that we also need to take a family history of any malignancy or any disease pattern in the family. So I think we sum up this case here and go to case 3. This is a typical scenario in our OPD. A 50-year-old woman presents with chronic pelvic pain that radiates to her lower back and thighs. She also experiences urinary urgency and frequency. And her pelvic examination reveals a little bit of prolapse. So, what next? What are we going to do now?
Ma'am, we have to take thorough history of this patient. When this pain started, whether she had any childbirth or any trauma in the pelvic area, and what are the relieving symptoms for pain, any position or any dietary modification, or we have to ask, of course, the psychological causes also, whether she is having any anxiety, depression, or any the personal issues in her life. Then we have to rule out the visceral causes of pain, like we have to do the ultrasound, especially TVS, and X-ray, spine, and the gynecological examination to rule out any mass, fibroid, adenomyosis, anything, or any infection if we are seeing in that. And we have to take the detailed history of bladder symptoms, like any burning is there, any for how long, any fever she is having, and urgency and frequency. We have to take the full bladder, history of this patient. Then we have to do investigation to rule out urinary infection, and of course the pregnancy first. Pregnancy also we will rule out. Then we will think of if type of pain, what type of pain, ma'am, is she is telling, radiate, and it's constant chronic pelvic pain. And if it is shooting type, or it is like a very shocking type of pain, then we may think of any neural pain for this diagnosis.
Okay.
Madam, one thing, as Dr. Parul sir was telling, that we have to do the pessary test. Like we have to put the pessary for a few months. If the pain is relieved with the pessary used, probably the back pain and the pain in the thighs may be due to the prolapse, which is dragging
so the
down
pessary
and
test is what you are
stretching on the
suggesting.
ligaments. Yes, madam.
Okay.
Okay.
Yes, ma'am.
Yeah, because see, in this particular patient, I would be interested whether she is postmenopausal and how many years of menopause she is into, because a very important thing that we come across is genitourinary syndrome of menopause with the passage of number of years after menopause. And because her primary symptomatology is mostly belonging to the urinary system, a urinary infection has to be ruled out. In spite of that, these women are more prone for recurrent urinary tract infections because they're never completely treated with antibiotics. And once that is ruled out, I would, of course, having done a thorough clinical examination, I would boil down my diagnosis to genitourinary syndrome. And to be very frank, these women respond dramatically to vaginal estrogens, topical estrogens, and the lower abdominal pain, the dragging backache could also be attributed to the prolapse. So that might need additional attention to see whether she requires a surgical correction or maybe just symptomatic or other lifestyle modification with pelvic floor exercises. Anyway, one important thing to be kept in mind is the postmenopausal atrophy.
Yes, totally agree with you. Ojaswini ma'am, you want to add something?
Yes, madam. So as I was telling about the pessary test, if it is the pessary test is positive, definitely you have to go for this corrective surgery, because probably she might have completed her family if she is 50 years old. But along with the treatment for the prolapse, you have to think of this urinary and the bowel habits, like this, whether there is any SUA, stress urinary incontinence there, or any overactive bladder is there. So you have to manage this problem also simultaneously. Otherwise, she may not be cured of this her symptoms.
Dr. Shweta? Dr. Shweta?
Yes, ma'am, I agree to everyone. Additionally, we need to see whether this back pain which is there is only because of the prolapse dragging sensation, or it is also because of something related, because 50 years old, you may have some osteoporosis or some nerve entrapment of the spines, which we get very commonly. So what we do is we give them a PMR or an ortho consultation, and they will advise which views to get, whether only X-ray or MRI. And many times we find that there would be impingement of nerves along with the prolapse. So depending on the grade of the prolapse, then we plan them for surgery. But before we plan for surgery, we will send a routine urine routine and culture, because many times we find that whenever there is urinary symptom associated with prolapse, infrequent, like incomplete voiding and all, there would be a infection also sitting in there, which we need to treat before we go in with our surgery. So these would be some of the other additional things that we would like to do.
We'll do cystoscopy also, ma'am, to rule out painful bowel syndrome, interstitial cystitis.
Ma'am, how
adding
do
on,
you
madam.
diagnose interstitial cystitis with cystoscopy? Yes, Dr. Rajesh?
And adding on this to the postmenopausal genitourinary syndrome and also the chronic cystitis, the problem is it can be also because of urethral syndrome. It is also a condition where any investigation culture will not be revealing any infection or anything, but the patient will be having all these urinary symptoms, dysuria, increased frequency of micturition, etc. And we will not have any investigations to rule out any other disease, ruling out other diseases. So it can also respond dramatically to the low dose estrogen or hormonal therapy. It will dramatically improve. It's one of the common causes of chronic pelvic pain.
That is true. So we've almost taken this through. Before we end this case, Shubha ma'am, would you like to add something?
No, in the history, of course, we have to look at what her obstetric history has been like, whether she, has had multiple deliveries and big babies, prolonged labor, the usual story for, prolapse, because she's just 50 and I'm sure she's not too many years menopausal unless the menopause is secondary to something else, like, surgical menopause or something like that. Because maybe the average age is, say, around 47 or something if she has had menopause. 2 years is a short time to cause all those changes, But she definitely is a candidate for prolapse because if she has had multiple vaginal deliveries. So that part of the history, and then I would recommend a pessary test after a thorough examination. And if she's relieved, then we know the cause is prolapse. Of course, as the prolapse stays in, the urinary symptoms also will improve if it is secondary to the prolapse itself. Rule out UTI, and then further you decide what you have to offer her. But if there are too many menopausal changes, which is unlikely, then I would give her a vaginal, estrogens and see how she improves.
Okay. So all of us gynecologists have a consensus on the pessary and also the estrogen, vaginal estrogen, because that many a time a woman will keep getting UTI. She's reporting 2 or 3 times a year, and just a little bit of estrogen takes care of her recurrence. So that is a really good takeaway, and especially when Lakshmi ma'am has just been to the IMS workshop conference.
I'm a staunch proponent of menopausal medicine.
Same here. I started when I was 30 and I've been doing it since. So now we go to case number 4. It's a 55-year-old woman who presents with chronic pelvic pain, which is characterized by burning and shooting sensation, often accompanied by numbness in the pelvic region and inner thighs. The pain is exacerbated by sitting for long periods and improves with movement. She has a history of pelvic surgery and radiation therapy for cervical cancer. So how are you going to approach this patient?
Who's taking that?
When the type of pain is neural type, because it's burning and shooting and associated with numbness also, and associated with postural element. And she has history of cancer surgery and radiotherapy, so mostly chances are of neural cause. So we have to think on that line. Of course, we have to rule out other causes also. It is associated. We have to do ultrasound and all, and routine gynecological examination, routine test to rule out infection.
And if you were allowed just one test, what would it be? That this is the first test that you want to do to this patient.
The leg raising test, ma'am.
No, that is a test that you would do. I'm talking about investigations. Which investigation would you like to do this on this patient?
We will put her in lithotomy position, the hip flexed, and if we press it, the examination, ma'am, or test.
Investigation, ma'am. Which investigation would you want to do? Just if you have a chance that you have to do only one, what would it be? The first one that you want to do. Come on. Dr. Shweta, you're sitting too relaxed. You need to wake up.
No, I was thinking this scenario is beyond my scope. So I will refer her to a neurologist, because there has been radiation therapy, pelvic surgery. Now she's getting that neuralgic pain. So I don't know. I don't treat this neuralgic pain. So I would want someone to do it. So it is neuro, or it is the pain clinic for me for this case. That's why I'm relaxed.
Okay, so you are in AIMS. That is because you are in AIMS. So now, Lakshmi ma'am,
because see, the problem here is she's a cancer patient. So definitely my first concern is whether she's going in for a recurrence. So I would want an imaging to rule out the recurrence, and then only I would think of in terms of a neuralgic pain. So I would want an MRI to be done.
MRI of what, ma'am?
To look for any recurrence of the disease.
MRI pelvis?
Yeah, MRI pelvis.
I think she should go for CAT scan.
Neuralgic pain. So you're not thinking of a CT of her spine? Because
okay. Oh, yeah, right.
Right? Because she has surgery and she also has radiation. So the first thing that you would think about is maybe a simple X-ray or an MRI of a spine.
Okay, right.
Right?
No, but definitely a recurrence has to be ruled out before we think in terms of
that's what. No, so if it is a bone recurrence, you'll get it on a CT. You would not get it on an MRI.
Yeah, sure.
So anyone has any difference of opinion? Dr. Rajesh, Dr. Sangeeta, Dr. Ojaswini, Indu ma'am, Dr. Jasmina, you're
No
all
difference of
there.
No,
Come on.
ma'am.
no difference of
Yes,
opinion,
ma'am.
madam.
Yes, sir.
I have no difference of opinion, madam. But the for line of investigation when we are going for these cases is that we do not cannot go with a one investigation
No,
because
the first one that you're going to take, the first one. It will not be just one, but the first one that you're going to advise.
yeah, since the neuropathic pain, even if you are going for an MRI also, you can also do an lymphocytic spine screening along with the MRI of the abdomen and pelvis. So
So that's
CT
why
as such,
I
it is
asked,
not
what are you going to do?
screening because it may be for coexisting neuro disease also. So that can be screened by, may not be found in the CT spine. It may be revealed only by an MRI of the lymphocytic spine. So that should also be considered.
Ma'am, for recurrence, it's a cervical cancer. Would you want to put in a speculum into the vagina? Do you want to do a pap smear, or you want to do an HPV from her vault?
Of course, all these are indicated, but you said one investigation. You didn't give us all the option of.
So now let us proceed with the further investigations. What else are we going to do? We've done her MRI. We've done her CT scan, and it is showing severe osteoporosis. And MRI is showing adhesions in her abdomen. Now what?
Both of these does not contribute to a nerve root pain. So in this patient, the patient is having a neurological pain. These adhesions, they can also cause the chronic pelvic pain, but may not be like this shooting sensation, burning sensations, and the numbness may not be contributed by the adhesions. So more likely, maybe the osteoporosis may lead to a vertebral body fracture or a spinal problem leading to nerve root compression. That may be a cause of this thing, or a post-surgery or chemotherapy nerve entrapment may also be a cause of pain in this patient.
Agreed.
Dense adhesion band may cause neural entrapment and may lead to neuropathic pain.
Okay.
Okay.
Because of his scarring and all after radiation.
So how are we going to examine for a pudendal neuralgia?
A digital examination, maybe vaginal and rectal, to scan the entire pelvic floor with a finger and elicit trigger points and see whether she has any particular point where the pain is maximum, which would definitely point to a pudendal neuralgia.
So that's what. So she had pudendal neuralgia secondary to surgery. Now we go to the next case, and that is a 40-year-old lady with a history of childhood sexual abuse presents with chronic pelvic pain that began after a recent traumatic event. She describes the pain as deep and throbbing, associated with feeling of fear and helplessness. The pelvic examination is unremarkable. So what is this and what are you going to do?
Ma'am, this is frankly a case of psychological cause of pain, chronic pain, because she has history of childhood abuse and recent traumatic event still. So whenever there is any psychological trauma that goes deep into brain, and whenever she recalls it, when she is low or she is in anxiety or she has other episode of this type of trauma. So definitely it's a case of psychological abuse, post-traumatic stress disorder, somatization of psychological cause.
So what are we going to do now?
Definitely, ma'am, the counseling and cognitive behavioral therapy and psychiatric medicine, maybe antidepressant, anti-anxiety, and the repeated counseling will help her.
So I think we are going to refer her to psychiatry, right?
Psychiatrist, yes, ma'am.
Exactly.
So we would refer her to psychiatry and they would do the evaluation, because I really feel when it comes to psychiatric disorders, we gynecologists don't have that kind of time to sit and talk to a patient for a couple of hours.
Yes, ma'am.
So now this is the next case. It's a 35-year-old lady who presents with chronic pelvic pain. It is accompanied by fatigue, joint pain, and low-grade fever. She also has a history of recurrent urinary tract infection, and now she has been diagnosed with IBS. Her in CRP kinase, they are raised. Lab tests reveal elevated inflammatory markers. So what could this patient be? She's only 35.
So, madam, this case may be certain immunological disorder in the form of autoimmune disease, in the form of either SLE or lupus. So, you have to take the detailed history about her menstrual history, her obstetric history, and detailed examination. Because in case of lupus, they are infertile or they have a very poor obstetric outcome. You have to take the history and see multiple symptoms in the form of joint pain, myalgia, fever, and also urinary symptoms and bowel symptoms. And the laboratory findings is also suggestive of some of the immunological disorders. So, thorough investigation rule out this immunological disorder and the different markers.
The lab tests are only showing elevated inflammatory markers. They are not showing autoimmune or anything. It's just an, you do a CRP and your CRP is coming raised.
Yes.
So,
so we have to, for this elevated inflammatory markers, you have to do further investigation to know what is the cause of this raised inflammatory markers. So that is a rheumatoid arthritis or SLE or it is a simple autoimmune thyroiditis or so many other causes of immunological disorders. We have to do further tests.
Lakshmi ma'am?
Yeah, this particular, she's a young lady, of course, and with a history of recurrent urinary infections and low-grade fever. Exactly how long has been the fever is not clearly known here, but I would think there's an element of immunosuppression, probably, which has to be thought of. And of course, there are certain viral infections which typically present with low-grade fever and joint pains and chronic fatigue, the chronic fatigue syndrome. Post-viral asthenia can be a feature. So definitely a thorough examination. A physician has to be involved here to rule out connective tissue disorders, autoimmune disorders, and you have to think in terms of those conditions as well. So it's not purely from the gynecological point of view that, of course, after ruling out all the gynecological problems for chronic pelvic pain.
Okay.
Whether it would be PID leading to all these problems, the pelvic inflammatory disease, tuberculosis of pelvis, low-grade fever, joint pain, and recurrent infections maybe because of PID, vulvovaginitis, all leading to all these problems. But the inflammatory bowel disease may not add up. Otherwise, it can also be a simple PID.
Well, if you have low-grade infection in your pelvis, then inflammatory bowel disease is just a collection of symptoms. You don't really have a test to say that this is inflammatory bowel disease. When they've ruled out something, they write it as inflammatory bowel disease.
Yeah.
So you have to actually think. You brought up tuberculosis, that could be one. It could be chronic PID, agreed. Anyone else has any input what it could be?
Gonococcal infections and also chlamydial infections can be chronic. So we can do swabs and see if she's positive for anything. Look at her cervix, whether there's any history of chronic white discharge. We have to ask, otherwise she may not come forth. And maybe some serological tests also will be necessary if there is history of, any previous history of PID. Or in these cases, sometimes we have to even ask subtle questions as to husband behavior so that we will know if it is an STI. We have to rule out STIs and as a cause for chronic PID, chronic infections.
Ma'am, in your practice, do you get HIV?
Yes.
Yeah, we do get.
Yes.
So if the husband is HIV positive and the lady has got it, she will also be having a lot of symptoms.
Yes.
Yeah, that's why I said one has to, this points to a state of immunosuppression, considering all the factors put together, the chronicity, the low-grade fever, recurrent infections, and things like that. So HIV also belongs to an immunosuppressed state.
So
Yes.
this could
I'd
be
like
an
to add-
SLE, but it could also be an HIV or
or a
tuberculosis.
lymphoma.
In our
We had
scenario,
one
that is
case.
what we have to think of. Yes, Dr. Shweta.
We had one case, ma'am, where patient always complained of fatigue. Hemoglobin was also 9, 10, like mild ranges. And there was low-grade fever, which was documented after admission also. And ultimately, she had a diagnosis of a lymphoma of the ovary. So many times these low-grade fevers, we should not think always it is infective. Because when we got, I think we did a CT for something and then there were nodes. So then we referred and then a biopsy imaging guided was taken. So ultimately it turned out to be lymphoma. So many times if patients complain of fatigue along with low grade fever, there has to be, this is not psychological or anything else. CPP may be secondary to it, but there is something else which is primary, which is lurking behind, which we need to find out. So CPP is what she's coming with, but what the body has would be something totally different, which we need to investigate. So this looks like a medicine case. We will involve the medicine specialists. They will do this connective tissue disorder workup. So many panels are there. But along with that, we also need to think that probably it can be any kind of malignancy also in a young woman. And this is the age group where we get these lymphomas. So many things we need to rule out. It's very
Good
rare, but then it
peripheral
does
smear
happen.
and
So we have to look for hepatosplenomegaly and look for any lymphadenopathy, cervical, inguinal, axillary, wherever. If you
But
find
it may
nodes,
not be there clinically. It may
yeah,
only
that's
be
what. It
coming
may
up
not
with
be there, but
imaging.
we have to do a thorough
We
examination.
have to look. Correct.
Because, I mean, you can help your physician colleague saying that, these lymph nodes are there, and they can go ahead and just do a biopsy, excision, or maybe even an FNAC that will clinch their diagnosis sometimes.
See, this panel is really turning out invaluable because different people, different insights, and we are seeing the lady as a lady and not just as a psychological wreck. Because
Yes.
otherwise, I have patients coming to me and they've been to a physician, an orthopedician, a surgeon, and she has 3 antidepressants written on her paper. Because it's not diagnosed what is actually wrong with her. And people think she's depressed, she is middle-aged, she has too much of housework, give antidepressants. So this panel is invaluable in the sense everybody gives insights how things can be organic and not just in the mind. So now we have a 32-year-old woman who has chronic pelvic pain that started shortly after giving birth to her second child via vaginal delivery. She describes the pain as deep and aching, worsened during menstruation and intercourse. Pelvic examination reveals pelvic floor muscle hypertonicity. So what is going to be your approach towards this patient? Nobody is speaking. Dr. Jasmina, you've been quiet for a very long time.
Actually, she's 32 years, very young patient. And there was a history of a second, like childbirth. Following to that, she developed this pain. So even menstruation intercourse. You have mentioned like there is a pelvic floor muscle hypertonicity. I think the pelvic floor muscles are very contractile. So maybe she will be having some myofascial tenderness in the pelvic floor. Contractile muscles are there. So I will ask her history like related to like sexual activity, whether she's having vulvodynia, like at the start of sexual intercourse, whether there is pain, or on the deep dyspareunia is there. Then I will ask like history related to pain during maturation or pain during defecation, whether she's having those pain. So what I can say, maybe because of excessive contractions of the pelvic floor muscle, she is having pain.
So basically,
Here, one thing
trauma may be focused.
I would like to add here is one thing. The pain is after the delivery, after, she's started having sexual relations, and is also related to her periods, right?
Yes, ma'am.
So one thing we have to rule out is any hypergranulation or granuloma formation along the episiotomy line or any other tear if it was there in the vagina. And secondly, endometriosis. Sometimes these endometriotic deposits can be seen along the episiotomy suture, or if there was any other tear where you have taken a stitch, or if you don't take a stitch and leave it, hypergranulation forms a granuloma, and these granulomas are very, very tender. So it has to be, we have to thoroughly examine her first and see what it is. And the fear of pain is one which causes the contraction and therefore hypertonicity of the, pelvic floor.
So once the organic problem has been ruled out, like as Madam said, the granulation tissue scarring in the vagina due to old heel lacerations and things like that, then I think a physiotherapist would be the best person to discuss pelvic floor relaxation exercises. Just as we have pelvic floor strengthening exercises, there are also ample exercises to relax the pelvic floor, and she needs a little bit of psychological counseling as well. So that should be the line of approach in case there is nothing seriously organic.
Also, this is a second child. So we have to find out whether, she has undergone a permanent family planning procedure, or is she on something. Sometimes the fear of having an unwanted pregnancy also can cause, some sort of a vague kind of pains. So that also we have to address. She may be fearful of the intercourse just because she doesn't want to get pregnant. And maybe she's not using some, method. She has not undergone a family planning procedure, and she doesn't want to get pregnant unnecessarily. So that also we have to kind of ask them.
Good point. Dr. Shweta?
Yes, ma'am, I agree to all of this. And yeah, nothing else. Nothing else that's coming to my mind. Maybe an Ayush consultation will do, because many times these yoga people, they do a very good job. So not only for strengthening, but also for pelvic floor relaxation, they'll advise exercise. So I would also go for an Ayush consultation and a yoga consultation for her.
Ma'am, we will see the deep PV examination to see any the deep tear in the fornices, posterior fornices and all. So that may
Yes,
also
madam.
be there.
Yes. And also, because she has developed this pain following the childbirth, and we have to ask about the mode of delivery, like any instrumental delivery. Like suppose a forceps delivery, there is a deep fornicial tear or the laceration or the hematoma in the muscle, in the pelvic floor muscle. We have to evaluate for that also. And any sepsis also, sepsis in the parametrium or in the paravaginal tissues may also lead to this dyspareunia and the pelvic pain.
So now we've done with our cases. If anybody has any interesting experience, I would like to know about it. And then I would like to have take-home messages from all the panelists. Any cases that you remember that, that were very important to you?
I can share one case where this was a doctor's niece actually. She came down from USA, and her main complaint was some pain in her pelvis for the last 10 months or so. And she used to say the pain was kind of, also radiating towards the left thigh region. And she had undergone a LSCS for a twin pregnancy in the US, and they had put a cervical stitch for her after that. Then she told me that after her delivery, at the cesarean only, they had removed the cervical stitch, and they had kind of shown her, see this, it was a proline blue stitch, she said. So it was shown to her that we have removed the stitch. And then she continued to, she started suffering that pain, and she continued to have that pain. She went back to the doctor. It's not very easy to go to the doctor repeatedly in the US. So she once went, she went once, she went twice, she went 3 times. And finally, they said that, it's something psychological only. But believe me, they had not done a pelvic examination. So when she came to me, I said, I need to examine you first. She said, no, why do you want to examine me? My pain is here, there, wherever. I said, I have to examine you. So when I put in a speculum, I see the proline stitch jutting out at the level of the internal, at the fornix. And I told her that I cut the thread, I removed. She said, thank you, my pain has disappeared. And it was dramatically gone. And then anyway, I threw the thread into the bucket, showed her, and then threw it. She said, but the doctor told me he has removed it and he showed me. So maybe, the long limb she has cut and not cut the knot, or he might have put 2 loops and cut only 1 loop. So many possibilities, right? And after an hour, she came back to me saying, give me the thread. I want to go and complain. I told her, don't do anything like that. And then I told her uncle, who's also a doctor, I said, it's okay. Sometimes it happens. Because if she had been in the US, I think she might have got some compensation. So that was a real dramatic case where, you don't expect things like this to happen. But that was causing her pain, and she suffered pain for 10 months post-delivery.
So it means, ma'am, we have to do all the tests like PA, PS, PV, all is
Very
necessary.
important. Clinical
Not only
examination is very
ultrasound and putting PV, the TVS probe.
Ma'am, today I got a patient. She's 93 born. For the last 6 months, she has distension and pain abdomen. Sometimes she's having constipations. Sometimes she's having a little hard stool. Sometimes she has pain during defecation. Bloating. When I put my hand on her abdomen, it was a 28-week size lump in her abdomen. And she had been going to multiple places. Nobody actually, unmarried girl, though she's 93 born, nobody put a hand just to see. She's having antacids, she's having Dufalac, she's having painkillers, and that lump is sitting there, a 28-week size lump. Sent her for an MRI, looks like a fibroid. But let us see. So the thing is, basically, what this whole chronic pelvic pain boils down to is, please give time for history. Please also examine the patient completely and then advise investigations. Don't take one-line history and start prescribing investigations. So I would like to have take-home messages from all of you before we end the session. Ojaswini, ma'am.
Madam, can I share my one experience?
Yes,
one
yes,
case?
go ahead.
Yes, ma'am. So one patient, she is pregnant, and around 28 to 30 weeks, she developed the gastroenteritis in the form of loose motion and vomiting. We thought it is just simple gastroenteritis and give the antibiotic IV. She recovered, but after 10 days, again she developed this gastroenteritis. So we thought she has not taken food from outside. Why she is developing this vomiting, loose motion frequently? So we do the upper GI endoscopy, and it was found to be a case of a huge gastric carcinoma. Ultimately, the patient landed with IUFD, a renal failure, and ultimately she died. And another thing that I was discussing, there is a case of sickle cell osteoporosis and this femoral head necrosis. A patient from West Bengal who delivered at West Bengal, but she had no crisis at all. But after the delivery, she was just having limping gait. And then the limping gait, she consulted the orthopedician, and when they did the X-ray, it was found to be femoral head necrosis. And almost half of the femoral head is necrosed because of the ischemic vaso-occlusive crisis, and it is found to be sickle cell E and S combined, heterozygous. S and E combination form was there, and later on she was diagnosed because of sickle cell, and she took the medicines later on.
Very important for us wherever we are practicing. Even our area has thalassemia and sickle cell anemia and all combinations. You may have AS with thalassemia as well, minor. So that is happening. So Dr. Shweta? Just some take-home points from today's evening.
Yes, very good history And please, an examination, a good clinical examination, including a pelvic examination for each and every woman who comes to you. If she's come to obs gynae, do a pelvic examination, then only send her. I mean, if it looks like a medicine case or a neurology case, don't simply write refer to them. You do a history, that 2 pages should be filled. Do a good history, do a good clinical examination. That's my take home.
Dr. Rajesh?
Yes, madam. Whenever it comes to chronic pelvic pain, always think outside the box, not just gynecological. Almost all the we are, though we discussed a lot of cases here, every time we are inclined to think about endometriosis all the time. So always better to think outside of specialty, think in other spaces. Try to uh, incorporate the examinations, like along with the gynecological examination. Some amount of orthopedic examination may also be down on the sleeve so that we can have some idea about what is happening in that patient.
Thank you, sir. Dr. Jasmina?
All everyone has said whatever, it's really correct. But what I observed, I have never given importance to tuberculosis while evaluating chronic pelvic pain. After this panel, I think I will keep in mind, we have to give importance of evaluating the patient, excluding tuberculosis when you are assessing or patient or evaluating a patient of chronic pelvic pain.
Thank you. Thank you. Dr. Sangeeta?
Yes, ma'am, but it is a case of chronic pain. So whenever she comes to you, already she had so many investigation and normal causes are ruled out. So we should not waste time in again repeating those tests, and we should think of other causes also and rare causes also. We should not think that it cannot be malignancy and especially tuberculosis and vitamin D deficiency. And in this scenario, premature ovarian insufficiency, we should think of the early onset of osteoporosis also.
Thank you. Thank you. Jaswini ma'am, your take-home message before I go to our experts.
Yes, madam. So as all of us know, this chronic pelvic pain is pathetic for the patient and also pathetic for the doctors, because we are very often we are not getting any findings and we are just counseling the patient, just try to tolerate it. All the doctors have seen, all the investigations and nothing is found to try to tolerate. But we should do a thorough history taking, thorough examination and investigation so that we can clinch the diagnosis so the patient will be cured. And sometimes the behavioral therapy in the form of certain yoga, pranayam, and certain watching this comedies, all these things can divert the attention of our sickness, and we have to counsel the family also, not only the patient. The whole of the family members has to be counseled to take care of this ailing woman.
Thank you. Thank you. There is somebody who's called Zoom user. May I know who that person is? Mehul, is somebody from your end?
मैं हूँ डॉक्टर आरती.
आरती मैम, इतनी देर से आप सुन रहे हैं तो कुछ कहना चाहते हैं?
नहीं, कुछ नहीं कहना चाहती मैं तो सुन रही थी. मैं कहा देखो क्या केसेस आ रहे हैं इसमें.
जी जी.
आप लोगों के इनपुट्स पूरे आ गए हैं.
Yeah. So as we've seen today, chronic pelvic pain is a multidimensional entity, and thank you, Dr. Asha, for choosing this excellent topic. And we as gynecologists should learn to see beyond the pelvis when it comes to chronic pain. And apart from a detailed history and clinical examination, it cannot be overemphasized. And I should say, to brand a patient as functional should be the last thing you do when you see a patient with this very distressing problem. And that should be only after psychotherapy should be done only after you have ruled out all possible causes that we've discussed. Thank you so much.
Thank you, ma'am. Thank you. Shubha, ma'am?
Yeah, I don't want to say anything because it would be a repeat of what everyone has said. So all points hold good, and we have to think out of the box. And, sometimes it is good to have these, like if you have 2-3 patients who are having this kind of a problem, it is better to connect them so that, they can talk and share their problems, because everyone may not give a listening ear, you know. So if they are having similar problems, they may listen to each other, and just talking might help them relieve of their pain. So that is very important. That's why we have so many of these self-help groups, you know. Each condition has a group, the endometriosis group and what all. So like that, I think we must try to help them. And it has to be a combined session with the spouses also, because looking at the spouse again is very important. What is his behavior? Whether he has extramarital affairs, whether whether she feels sexually satisfied, and her sexuality, everything is addressed properly or not. So all these aspects are very important. And definitely yoga, some exercises do help, especially for the pelvic congestion syndrome. And one thing we have to keep in mind, apart from all the diagnoses, is chronic pelvic thrombophlebitis. Very difficult to diagnose, but if it's a bigger vessel, there will be some manifestation. But if they are smaller vessels, the manifestation is not going to be much. It will be chronic pain. So that's one thing we have to keep in mind. If there's some underlying vascular pathology, that could happen. Thank you. Thank you, Dr. Asha, for having me here. It was indeed a great pleasure interacting with all of you all. Thank you so much.
Thank you, ma'am. Ma'am,
Thank you.
to your thrombophlebitis, I would like to add one thing. I do my gynec scans myself. And when you put in a Doppler and you see the vessels behind the uterus and on the sides below the tubes, you know, you will find the vessels are much thicker. They will show aliasing. That is there when the patient is having that pelvic congestion syndrome, which is a precursor to having that thrombophlebitis. And those patients really respond well to Dobecil. Means I've tried it for 6 weeks and it works.
That's
and,
good.
Dr.
The
Beena Singh,
case that I had, the case that I had looked at was actually a CA ovary. You know, where it was a small ovary. It was not a very big ovary at all. But she had thrombocytosis, secondary to which she had pelvic thrombophlebitis. I mean, pelvic thrombosis. And she had come only with history of pelvic pain for lasting some 2 months or 6 months. I mean, if you go by definition, it should be 6 months. But in her case, it might have been 2 to 3 months. But nowadays, because of the imaging, it was picked up immediately. It turned out to be CA ovary with her platelet count was something like 6.5 lakhs. So that is why she underwent, of course, surgery and all that.
Dr. Beena ma'am has joined us. Beena ma'am. Dr. Sujayshri.
Ma'am, I'm here, ma'am. I
Yeah,
think
yeah.
everyone has mentioned everything which has to be said. So it was a very good panel, ma'am. I hope all the people who have logged in will benefit from this.
So thank you very much. Thank you very, very much for being here, spending the evening and sharing your knowledge, because I hope anyone who listens will have a broadened view because of the searchlight that we've put on chronic pelvic pain. I hope to see you again in some other webinar. And I will be going for Chairperson, Food, Drug and Medico-Surgical Committee. I seek your nomination and support.
Wish you all the best, ma'am.
Thank you.
You have all our support. And thank you so much for having me here.
Thank you, ma'am.
And it has been wonderful interacting
Thank you,
with
ma'am.
all
It
the
was
panelists.
wonderful.
Thank you, ma'am, for
Thank you.
putting
Thank you,
forward.
everyone. Good.
I request everyone put on your videos for a minute so that we can take a photo.
Yeah, definitely.
Everyone, please. Yeah. Dr. Rijesh, Dr. Sangeeta, Dr. Beena,
Yes, ma'am.
please put on your videos for a minute.
Please put it in the group.
Yeah, that's it.
I will definitely put it, ma'am.
Yeah.
Dr. Rijesh. He wrote
Dr. Beena, if you could also
disappeared.
switch on your camera.
Huh? So I've taken
No, I was requesting.
Smile, please. Yeah. Welcome, Dr. Beena. We missed you initially. If you have something to say, we are there to listen to you. Everyone is here. Yes, thank you.
Rijesh is not there.
Yeah, he's joined. He's joined.
Okay.
Beena ma'am, you're muted. You're muted.
Yeah, hi. Am I audible now?
Yeah,
Yes,
yeah.
yes.
Yeah, I joined earlier. I just attended the session of Dr. Parag, the chronic pelvic pain. The
But
first
then you
session,
didn't
yeah,
speak
first
up. You
lecture,
didn't
yeah.
speak up.
Somehow, because I just started later, I was downstairs in the hospital. Sorry for that.
No, no, that's all right. We are glad to have you here. Any input that you have after you've listened to us all?
Yeah, it was very, very nice session. And all the very, very best for you.
Thank you. Thank
And
you.
your background is awesome.
Thank you. Thank you. Mehul ji,
Okay,
dhanyavad.
bye-bye.
So namaskar, all panelists, chairpersons,
Thank
all
you so
our
much.
experts and Corona Remedies. Thank you, Sujayshri, for being here. I hope we have all enjoyed this evening and invite you again to the further webinars. We have a webinar every Wednesday. Next week, the Searchlight is going to be on breast cancer and pregnancy. That's another thing that I don't think everybody is alert about. So it's cancer with breast cancer with pregnancy and pregnancy with breast cancer, two separate topics. That is the searchlight for next week. Welcome
We
all.
are waiting for that. Yeah. Okay. Bye-bye.
Namaskar. Good night.
Namaskar.
Thank you.
Good night, everyone.
Good night.